Hello, and welcome. This is our last webinar in our PCOS series. I am Tamara Tobias. I am a nurse practitioner I work at SRM in our Bellevue location. Today we're going to talk about treatment options, and we are going to start with a short presentation followed by questions. So if you could please use the chat feature to post your questions, and so we can go over those at the end. And so now I am going to turn it over to Julia.
Hello, thank you, Tamara, and thank you everyone for being here. I am so excited for our last webinar. It's been really fun and interesting. And so today we are going to talk about fertility, and we are going to talk about treatment, pharmacologic treatment. And these are really broad topics, and so just with the limitations of our time, we're going to cover pretty broadly and not in great depth, but there will be chance at the end for questions. So and I apologize, I'm nurse practitioner up at our Everett clinic. And so to get started, I think it's important to recognize just off the bat, as you may have realized if attending the other webinars, that PCOS is not just irregular periods and infertility. However, those kind of loom large in people's minds, and many people are diagnosed when trying to conceive. But we also want to recognize and treat all the secondary features that can result from the, hormonal imbalances and the insulin resistance, such as symptoms for acne management, unwanted hair management, anxiety, depression. And then while this talk isn't going to delve into management of cancer or diabetes or heart disease, it's important to know that those are long-term risks that lifestyle and being aware of that they exist are important to recognize. All right, so just moving right along to fertility, if we could just, perfect, thank you, Sarah. I feel like this one is a huge issue. This is what people think about with PCOS. Many women were told that if they have PCOS, they can't conceive. And it's true that PCOS is one of the most common, but it's also one of the most treatable causes of infertility. We see it in 8 to 10% of US women. And the difficulty conceiving comes from those hormonal imbalances that prevent normal ovulation. And then even once people are able to conceive, their pregnancies are higher risk. There's a significantly higher rate of miscarriage, up to 40% higher than the general OB population. And we really don't know exactly why this is, which is a really depressing thing to hear, but we think it stems from the elevated androgens and potentially the insulin resistance with the elevated circulating insulin as well. Additional risks include higher risk of gestational diabetes, high blood pressure, so preeclampsia as well, and preterm delivery. And those all sound really, nobody wants to hear that. It's hard to get pregnant and then you have a higher chance of having a high risk pregnancy. But the good news is that, one, all of those dietary changes, the pro-fertility diet, the increased physical activity can, in some cases, help restore normal ovulation. And even in the cases when it doesn't and we need ovulation induction to help, jumpstart conception, the ovaries tend to be more receptive to the ovulation induction, and those changes, those healthy changes, can lead to improved pregnancy outcomes. All right, so next slide, please. This lovely picture is the hypothalamic pituitary ovarian axis. And just to reassure you, I am not going to do an in-depth lecture on reproductive endocrinology and physiology, but I just want to give people a quick overview, very, very basic, of what's going on with normal ovulation, so you can get an understanding of where PCOS can kind of interrupt that process and how ovulation induction medications work. So you can see here that ovulation requires communication between the brain and the ovaries, and this is done through a number of different hormones. And the ones that we care about for the purpose of this talk, and again, very simplified, is the gonadotropin releasing hormone that's released by the hypothalamus, the follicular stimulating hormone released from the pituitary gland, and estrogen released from the ovaries. And in normal ovulation, where everything's proceeding smoothly, at the start of a cycle, the estrogen level is low. And so that tells the hypothalamus that it needs to release the gonadotropin releasing hormone, which lets the pituitary gland know to release follicular stimulating hormone, which then lets the ovaries know that it's time for an egg to start maturing and growing. As that egg matures and grows, estrogen levels increase, and that serves as a negative feedback to the brain to decrease the amount of follicular stimulating hormone, saying, hey, things are working, you don't need to keep releasing this, can kind of cut back. In PCOS, for reasons that we don't know but we suspect are related to elevated androgens and insulin resistance, the ovaries, normal ovulation doesn't happen. And the ovaries often have all of these little arrested eggs on them. So they've started to mature, but they just don't. They just kind of sit there. And so estrogen, and that's part of why estrogen levels are so high in these patients, because they're just releasing androgens and releasing the estrogen. And so the body just doesn't release that FSH. It's this vicious cycle. And so, and so ovulation induction works by increasing the FSH levels in the body and then signaling to the ovaries that, hey, we can move forward, we can release this egg and hopefully have conception occur. All right, so ways that we can work with ovulation induction, and I'll just have my next slide. Please, thank you. So I think a couple of medications that we work with, and I think also people, when they hear fertility treatment, they think that IVF immediately. And that's often not needed unless there's other factors. You can start with low-tech treatment. And most of the time people respond really well to oral medications. So our first line medication, the one that we recommend and that most people, SRM, most of our providers use, is Letrozole. And that's an aromatase inhibitor. You don't need to worry exactly what that means, but it blocks the production of estrogen from the precursor hormones. And so lower estrogen means higher FSH, and you can go from that top ovary, which is what we call a stereotypical PCOS ovary with all of those little follicles arrested there, to the bottom ovary with that nice big mature egg ready to ovulate. And I think some people have heard bad things about Letrozole because it's not FDA approved for use in fertility. It was originally developed for breast cancer treatment, but I think there's been 42 or more randomized control trials that have shown that it actually works better than Clomid, which is the other option, and there's fewer side effects. And just because something is used off-label doesn't mean it's safe. And I think Letrozole got its bad rap way back in the early 2000s with a poorly designed study that showed a potential increase in risk of birth defects, and that finding has never been replicated. And in fact, by the time fertilization happens, Letrozole is gone from the body. So we do like Letrozole. All right, and then we'll move to the next slide for the last bit about ovulation induction. However, Letrozole is not our only option, and we always want to see our patients as individuals. They're not statistics. Not everyone responds well to it, no matter what the general consensus is. So Clomid remains a really good option. Clomid is what people think, fertility medication. And it works by actually blocking estrogen receptors in the hypothalamus, which leads to the brain thinking there's not as much estrogen, and then leading to the increased level of follicular stimulating hormone. There's much less of a side effect profile with it, there's much more of a side effect profile with Clomid than with Letrozole because it's non-selective, and it's, instead of just decreasing estrogen, it's actually blocking those receptors. It also, so you have like the hot flashes and the brain fog and the joint achiness. And then it can block the receptors in the uterus, which can lead to a thinning of the endometrial lining. Additional option, but not one that we use commonly with PCOS, is low-dose gonadotropin, so actually giving injections of follicular stimulating hormone or in combination with luteinizing hormone. Now, some people are like, why don't you just give me the FSH if that's what we're looking for? And there's a number of good reasons. One, it's expensive. It's not necessary for most patients with PCOS. You have to give yourself multiple injections, and you really need to do mid-cycle ultrasound monitoring to make sure you're not having somebody have too much of a response and putting them at higher risk of multiples. And then a final word about metformin. Metformin can actually be very helpful if there's insulin resistance. It's the same thought process as the pro-fertility diet, where you're really trying to lower the circulating levels of insulin and hopefully restore normal ovulation. It doesn't always work well on its own, but again, in conjunction, it can potentiate the effects of the ovulation induction medications. So don't write off metformin as a helpful adjunct. And with that, I'm going to pass it on to Tamara, who's going to talk about the bane that is irregular periods.
Thank you, Julia. So I'm briefly going to discuss non-fertility treatments with PCOS. So as Julia mentioned, PCOS, those with PCOS have irregular menstrual cycles. When you have irregular menstrual cycles, you don't have a monthly period. And by not having a period every month, that lining of the uterus can begin to build up and become thick, and is an increased risk of uterine cancer or endometrial cancer. So the first line of treatment is birth control pills. And birth control pills are a wonderful option as a first line of treatment because there's two really main benefits. The first benefit is that birth control pills can help lower the androgen levels. Androgen levels are those male hormones, and it's the male hormones that cause so many of the side effects that we see, or the symptoms that we see with PCOS. The other thing it does is that it protects the endometrium. So birth control pills help keep the lining nice and thin, so it's not building up and increasing the risk of cancer. And you can take birth control pills continuous. And if you take them continuous, this may really help with keeping those hormone levels suppressed. So you can take birth control pills continuous for about 3 months and then take a break. Most women tolerate birth control pills with minimal side effects. There are some few contraindications for taking birth control pills, such as a history of blood clots or history of breast cancer. And you can check the CDC website or talk to your provider to see if there's a contraindication for taking birth control pills. We do like to start with the lowest estrogen level first. When we're picking pills, there's numerous birth control pills out there. So we try to start with the lower dose, but we may have to increase if we're not finding that it's effective. And then you like to start with the progesterone component in birth control pills that has the lowest androgenicity. So again, lowering that androgen levels. Next slide, please. Alternatives, we can use the NuvaRing or the Mirena IUD. What's nice about that, it does have progesterone in it, and that progesterone keeps the lining of that uterus thin, again, decreasing that risk of endometrial cancer. Progesterone-only pills may be used. Those are also called mini pills. Cyclic progesterone, that means taking a prescription of progesterone, and this progesterone is given every 2 months, and taking this every 2 months or every other month to cause a withdrawal bleed or to cause bleeding, because we want to have that bleed to, so we don't have that lining build up and increasing that cancer risk. Metformin, like Julia mentioned, metformin can be helpful, especially if there is signs of insulin resistance in the blood work. Just a couple comments on metformin. Metformin is an insulin sensitizer. It can be, for side effects, it can be kind of upsetting to the GI tract and kind of cause that stomach to be upset. So we want to start low in the dose and then gradually increase as we're tolerating the medication. It also can impact liver function. So it's important before starting metformin that we check liver function tests to see how those are looking, and then we check them once a year as well. And long-term use of metformin. So if we're on metformin for over a year, it can actually cause vitamin B12 deficiency. So we'll want to check vitamin B12 or go on a vitamin B12 supplement. And then just a comment on myo-inositol. Myo-inositol is as effective as metformin and often much better tolerated with few, if any, side effects. And the reason is because it's a natural supplement. It's found in fruits and grains and nuts, and it's also found in our bodies. And so it's a natural supplement. And what it does is it helps decrease that insulin resistance, again, dropping the androgen levels and keeping and bringing down that male hormone. Okay, next slide, please. And then lastly, we look at other symptom management. So for symptom management of acne and excessive hair growth, which is called hirsutism, it really depends whether or not a person is attempting pregnancy, what you're going to choose, because a lot of these medications are not safe in pregnancy. So if we're attempting pregnancy, we can use topical agents such as benzoyl peroxide. We can use some topical antibiotic creams such as Cleocin. Some oral antibiotics such as erythromycin can be taken. But if we're not trying to get pregnant, the number one choice is birth control pills again. Again, birth control pills bringing down those androgen levels. We can try other topical agents if we're not trying to get pregnant, such as Differin gel or Retin A. You can try oral antibiotics such as doxycycline or Accutane. Accutane is something that we do not prescribe here at SRM because in order to prescribe Accutane, it requires a registration with the iPledge program, and you have to be on 2 really good forms of birth control pills, birth control for Accutane. Because it is absolutely not safe in pregnancy. Excessive hair growth, again called hirsutism. Looking at if you're attempting pregnancy, we don't have a whole lot of choices, unfortunately. We can look at light therapy or electrolysis. But if we're not attempting pregnancy, number one choice again is birth control pills. Try that for 3 to 6 months. But if you're not seeing the symptoms of the hair maybe going a little bit lighter, we can then talk about using a medication called spironolactone. This blocks testosterone, so it is a prescription. It blocks testosterone. It is absolutely not safe in pregnancy, so you have to be on a really good form of birth control. The side effects with this one, it is a diuretic, so we want to check kidney function before starting it. And then you are at risk for having really high potassium because it is a diuretic, so you want to watch the fluids there. Other side effects include nausea, fatigue, and decreased libido. What's important to know is none of these medications are going to work right away. It takes time. It takes time for birth control pills. It takes time for the spironolactone. It could take 4 to 6 months before seeing any improvement. So it's a lot of patience. We could also look at laser hair removal, light therapy, or electrolysis. And then lastly, there was one prescription. It's the only topical treatment available for hirsutism, and it's called Vaniqua. This is a topical medication that you can put on your face or chin. It's not going to it's going to slow the regrowth of the new facial hair. It's not permanent, but it's going to slow the regrowth. And that's something that can also be taken. Okay, I am now going to send it back over to Julia. Next slide. And we're going to wrap it up.
Thank you. So just briefly talking about depression and anxiety. This is not to minimize the impact of depression and anxiety. It is not to minimize the need for pharmacologic treatment. It's just most people already are well aware of the options of medications that are out there, the SSRIs. I just want to say a few points. One, we know that depression and anxiety is higher in patients with PCOS. And we also know that patients who have infertility have higher rates of prenatal, so depression while they're pregnant, anxiety while they're pregnant, and then postpartum depression and anxiety. And so I feel like there's still a lot of stigma about needing medications to help treat depression and anxiety. And our last webinar really went well into some of the non-pharmacologic modalities that we have, talking about mindfulness techniques, working with a counselor, but sometimes medication is needed, and it's not because someone hasn't tried hard enough not to be depressed or not to be anxious. That's not how it works. It's just as important to think about the mind and recognize that you can't will yourself out of depression. And so please screen your patients, work with your patients. And if you have patients who are trying to get pregnant or are already pregnant and neither you think they might need medication, or they think they need medication, or they're already on a regimen that works for them, most of the cases, with the exception of Paxil, we don't want you to stop their medication. In fact, the general consensus is coming to be that the long-term impact on fetal development and health of offspring moving forward is more negatively impacted by untreated depression and anxiety during pregnancy than anything that the medications would have. And we do know that untreated mental health has really high morbidity and even, unfortunately, mortality rates. So we really want to be conscientious of screening and treating with either non-medication or medication in combination. All right, so we have reached the end. So we'll just go to our next slide just to wrap it up. And I think the common theme that's been through all of these webinars, both diagnosis and all of the different ways that we can work to help treat PCOS, is that there's no magic pill, unfortunately. There's no one-size-fits-all treatment. It's very, very common, but it's multifactorial, and how it presents in one patient is not going to be the same necessarily as it is in another patient. So successful management can take some patience and some trial and error, and it often involves a combination of the lifestyle and medications to really be successful. But if you're able to find somebody where you can work and come to share decision making about your goals and your values, I think really good outcomes. We can have really good outcomes. So thank you so much. I think we go to the next slide. And we are going to open it up. We're going to look and see what our questions are. I definitely see some that have come in. And then we have a phone number here and website if you have information about learning more. Tamara, do you want to take a look, or can we see what our questions are that are in the chat?
Yes, let's take a look. So the first question that has come through the chat: does letrozole have the crazy range of emotion and symptoms like Clomid? Julia, you can hop on that one.
Yeah, so most of the time people have fewer side effects, fewer ranges, like fewer of those side effects that they would experience with Clomid. Now, estrogen levels are still lower, so they may notice that they feel some hot flashes, they may notice some emotional lability, but most of the time it's a little better tolerated because we're not actually blocking the receptors. There's still some estrogen that's available.
And that leads to the other question about letrozole: does it affect the uterine lining? And it does not. It is not like clomiphene. It does not impact the uterine lining, and that's why it's really our go-to for our first oral ovulation induction medication here at SRM. Next question that came through is: how do you test for PCOS? How do you know if you have it? And this one, I really encourage you to check out our other webinar series earlier, where we went through the testing, the diagnostic workup. But it's pretty straightforward. There's some blood work that we would do to screen for it. And then we really look at the Rotterdam criteria. And you need to have 2 out of the 3. So irregular menstrual cycles, hormones that have the increased androgens, looking at the hormone results, and then an ultrasound, which shows those polycystic ovaries or all those follicles on ultrasound. Next question: if you bleed every month but do not ovulate, are you still at risk for uterine cancer and complications?
And I think if you're having a regular bleed where you're bleeding every month, then most likely you are not at the complication at risk. It's the buildup of the lining, the endometrial lining, and the exposure to unopposed estrogen that can lead to the changes in the cells and the overgrowth of endometrial cells that put you at higher risk. Okay. And then the next question: is there a specific brand of myoinositol supplements that you recommend? And yes, there is. It's Avastitol, and it's by
Theralogics.
Theralogics. And so that one is either for patients who are trying to get pregnant or just in general for helping to manage some of the symptoms. Okay. So next question, do PCOS women have any higher risk of difficulty getting pregnant or ovulating after stopping birth control pills? So meaning that if a PCOS woman is on birth control for 6 months and stops, are her chances similar or worse than non-PCOS women? Unfortunately, stopping the birth control most of the time is not going to lead to regular ovulation in the future if you stop it. You still often will need to either have the decreased insulin and the androgens that's going to come back if you stop the birth control. And so most of the time we do need to use an ovulation induction.
I'll comment on that one as well, including with our previous webinars, we talked about lifestyle modifications. So looking at nutrition, our exercise, our fun movement, perhaps adding myelin and inositol. And when stopping birth control pills, by doing all those things, you may be able to resume a normal menstrual cycle on your own. But like Julia mentioned, if you don't, the birth control pills are not going to impact it. It just means your body is not going to go back to a normal ovulatory pattern. So we may need to help with ovulation induction medications such as letrozole.
Is our next question. What can I expect in my first fertility appointment? So it depends on if your appointment is specifically with the PCOS or if you're working for other things. So usually we go through your medical history. We get an idea about how long you've been trying, what you've tried in the past, has anything worked, and then we're going to get lab work and ultrasound, order lab work and ultrasound, and then based on those results, come back and come up with a plan working with you. And that's kind of a very basic overview. I don't know if Tamara has anything else she wants to add to that.
No, I totally agree. Yeah.
Okay.
I was reading the next question. So next question is, what interventions serve to reduce miscarriage in women with PCOS patients? We mentioned diet and activity, but is there anything else specifically?
Well, I think we can talk about a little bit about diet and activity, but we have, if you look back at our previous webinars, there's one specifically talking about diet that's like pro-fertility diet, which would be, low pesticides, fruits, whole grains, seafoods, limiting dairy, things like that. And it really goes, because there's not a perfect diet, but there's a lot of different options that can be helpful in decreasing the insulin resistance. And then activity-wise, it's making sure you get the 150 minutes of moderate physical activity a week as a minimal. But I would refer you back to the previous talks for more in-depth information about that.
I would also comment on myo-inositol. That could be a nice supplement that can help. Taking your prenatal vitamin every day. And it is hard to hear about PCOS and miscarriage, but the number one reason why women have miscarriages is advanced maternal age. So age plays a big component in that as well. So being proactive and talking about age.
Okay. What kinds of tests can I expect to be run for fertility testing? I think we've kind of covered that with the blood work and ultrasounds.
Yep.
Okay. And then as letrozole is not FDA approved, is it something that patients are responsible for 100% out of pocket? That depends on your insurance. A lot of times insurance won't cover anything for fertility medication. It's not a question of it being FDA approved or not. It's a question of our country's priorities about what we cover under insurance. The good news though is that letrozole is really inexpensive, so it's not it's not going to cost hundreds of dollars out of pocket.
Yeah.
But that would be something to check with the patient's insurance.
Next question is, how long should a patient try letrozole before stopping or trying another medication? And this is a great question, and Julie can comment as well, is it really depends if it's working. So it's important for us to follow to see if the dose if we give you or give the patient is working or not. And we may have to increase the dose until we find the appropriate one that's going to induce ovulation. And once we find that appropriate dose and we're inducing ovulation, we want to try at least 3 to 4 times if we're getting ovulatory cycles. If we're still not pregnant after 3 to 4 times and we know they're ovulating, either they're getting a period or we check a progesterone level, make sure they're ovulating, then I would look at partner, make sure we have sperm, right? And make sure that's looking good. And then maybe if that looks good, maybe we talk about increasing some more things. So perhaps adding an insemination onto it. So typically when we look at success rates, they do start to plateau. If you just look at success in general, it starts to plateau after about 3 to 4 cycles. But I would give it at least that many time, even up to 6 months. Julia?
Yeah, I would say if you're getting a response, so if you're not getting a response, obviously, then we're going to decide that it's not the right medication and try something different. But if you are, we're thinking like, even with perfect ovulation and timing, it's a 15% chance of pregnancy per cycle. And that's just in general, 15 to 20% for a healthy, normal person who's ovulating on their own as well. And so you have to give it a few months before you would reassess, just knowing that it doesn't happen immediately for most people. Next question is, I've heard getting the gastric bypass surgery greatly increases your chance of getting pregnant. It does increase your risk of a high-risk pregnancy. Just wondering if this was true. Thank you for this series. You're welcome. It has been very helpful. Well, so gastric bypass surgery has been shown to be one of the few ways to cure diabetes. It can for people who have type 2 diabetes. And so that can help with getting pregnant. But yes, it would put you at a higher risk. And so that would be a question, I think, to cycle back to your GYN as well about that.
Next question is, can you do Clomid or Femara while breastfeeding? And not recommended. So I'm sorry, but yeah, because it can cross the breast milk, and that's something that we would not want to give hormones to the baby.
And then looks like we've put in the brand of the myoinositol. Sarah has already done that. And then the last question is, can we access the past PCOS webinars? And yes, the links are not yet on our website, but they will be there, and they'll have links to all 5 of these. So you'll be able to go back and watch the previous ones.
And just a quick comment too, we really appreciate doing the survey. We will be sending out a survey. And so we really appreciate any feedback. So after the seminar, you will get a survey, and you will also get a link to all of these series if you've registered. And like Julia mentioned, we will be eventually posting these on our website for you.
All right. Oh, some more questions. If someone is successful getting pregnant with letrozole Clomid but has miscarriage, should they continue trying to conceive with those medications? So if it's the first time that you've had a miscarriage, then yes, you can definitely keep trying to conceive with those medications. The majority of miscarriages happen, unfortunately, because of a genetic abnormality in the developing pregnancy that makes it incompatible with continuing to have a successful pregnancy. And so that's not related to the use of the medications. It's just a random occurrence. Now, after your second or third miscarriage, that's when we recommend that you start an evaluation for a recurrent pregnancy loss. And we would want to kind of do a deeper dive and maybe take a pause on trying to conceive until we can figure out if there's something that's causing you to have the miscarriages outside of random tragedy. All right. I think
we got them all.
That is everything. And we only went a few minutes over. So thank you so much for your patience and letting us get all this information out to you.
It is a lot of information, and we're, like Julia said, we are super excited to have brought this new program to you, to SRM, this new PCOS wellness program. And it's really, we want to outreach, we want to teach, we want to educate and empower. So thank you.
Thank you so much, everybody.